Colin Bernan. I'm the chair of corporate partnerships for the meeting, and welcome to all. So I'd like to introduce to you our special guest for today, our keynote speaker. Emery N. Brown is the Edward Hood Professor of Medical Engineering and Computational Neuroscience at MIT, the Warren M. Zapol Professor of Anesthesia at Harvard Medical School, and a practicing anesthesiologist at Mass General Hospital. He is an anesthesiologist statistician, with an unusual combination, whose experimental research has made important contributions towards understanding the neuroscience of how anesthetics act in the brain to create the states of general anesthesia. In his statistics research, he has developed signal processing algorithms to solve important data analysis challenges in neuroscience. He received his BA in Applied Mathematics from Harvard College, his MA in Statistics from Harvard University, his MD from Harvard Medical School, and a PhD in Statistics from Harvard University, all with highest honors. Dr. Brown serves on multiple NIH committees and the boards of private foundations, including the board of directors of the Burroughs Wellcome Fund. He is the recipient of an NIH Director's Pioneer Award, an NIH Director's Transformative Research Award, and the 2011 Jerome Stacks Award for Outstanding Cross-Disciplinary Research from the National Institute of Statistical Science. Dr. Brown is a fellow of the American Statistical Association, the American Association of the Advancement of Science, the IEEE, and the American Academy of Arts and Sciences. He is a member of the Institute of Medicine and the National Academy of Sciences. So it's my clear pleasure, and please join me in welcoming Dr. Brown to the podium to deliver his keynote address on the dynamics of the unconscious brain under general anesthesia. Dr. Brown.
Colin, thank you. Thanks to the committee for inviting me. It's truly an honor for me to be here and to talk about anesthesia. Not something we talk about every day. You know, I'm sure you don't have a cocktail party conversation about anesthesia every day. But I'm going to change that, you know, after this. So this is the outline I'm going to follow. I'm going to give you a little sense of what anesthesia really looks like from a clinical perspective, or what actually happens. Then I'm going to speak specifically about Propofol. We've done a lot of studies on Propofol in detail. It's the most used anesthetic. Then I'm going to talk about closed-loop control of medical coma, a topic which literally just before I came upstairs here a second ago, I think they just placed Joan Rivers in a medical coma. Should I just come a little closer? How's that? Okay, sorry. So as I was saying, they just placed Joan Rivers in a medical coma, I think because of the heart attack she had yesterday. And so this is actually relevant to that situation. And then I want to talk about something about the future, like awakenings from anesthesia, all right? Then I'll have a few summary comments. So this is a clinical look at general anesthesia. So how many people here have actually had anesthesia? Okay. How many people have seen other people get anesthesia? Oh, okay. All right. So I'm going to fix that for you in just a second. So let's start with a definition of what general anesthesia is. So it's this drug-induced state. It has to be reversible. All right. It has unconsciousness. You're not supposed to be aware. You're not supposed to remember what happens while you're under anesthesia. It's not supposed to hurt. It's nice if you're not moving around while the surgeons are operating. And if you stop there, those four things there are synonymous with death. All right. So you need a little bit more. So where we really earn our money is in maintaining the stability and control of physiological systems, all right? And so it's said that it's not clear how anesthesia works, and one of the things I want to leave you with today is that nothing could be further from the truth. I think there's very obvious ways that it's working, and it's just that we really, as shocking as it sounds, we just haven't paid attention. So I just want to start by just showing you a little video of this. So this is a gentleman who, just one Friday afternoon, Eric Pierce and I, one of my colleagues, we just went over to just film someone going off under anesthesia. So this gentleman has an umbilical hernia. He's 68 years old, and he's just going to have a hernia repair. It's a surgery that should only take about 15 minutes or so, but he's going to have general anesthesia for it. And so the first thing I did was just have him track my finger. I just wanted him to follow my finger. All right? And so here, I'm turning his head, to the left, and his eyes go to the right, and vice versa. This is the oculocephalic reflex. It's just a very quick way to check to see that the top of the brainstem is intact. All right, and I'm going to have him do that. We're going to check that later on. And I just want to show you here, he's got normal motor strength. He's not weak at baseline, so I'm just having him pull against me just to show you what he looks like. All right. Now, if you've never seen this done before, one of the things that we do at the outset here is the nurse is having him breathe 100% oxygen. And she's doing that because when we have difficulties with anesthesia, it's usually at the beginning or sort of at the transitions coming out. So we're going to make him profoundly unconscious. He's going to stop breathing. His airway could shut down. And if we're unable to intubate him and we filled his lungs with oxygen 100%, then it gives us a time frame, the 3-4 minutes when we can get help or execute some emergency maneuvers. So that's what she's doing now. Okay, so right here where the words come on the screen, okay, right there, we're going to inject 150 milligrams of Propofol, all right, sort of standard induction dose. And this isn't edited, this is just real time. So he's out. He's unconscious now. All right? Now she has to breathe for him now because he stopped breathing. All right? And we'll just show you just how profoundly unconscious he is. So look, I turn his head now. See, his eyes are fixed in the midline. So if you came across this guy on the street, he's basically out. He's unconscious. He's in a coma. All right? But you can't hear it, but his heart is still beating. So he's perfectly fine. He's okay. All right? All right. All right. And you can see he's unresponsive. Now check his arm out. Watch this. So his arm's spaghetti, all right? All of a sudden, his muscle tone has changed dramatically, all right? That's just with this one dose of Propofol. All right, now, let me just show you one other thing here, all right? So I didn't have his EEG, but this is just the EEG of someone who had just a similar induction. So this is a lady she's 62 years old, and she's going to have thyroid surgery. And so this is her EEG, and we're going to do exactly the same thing. We're just going to give her a bolus dose of Propofol. I just wanted to show you just how profound the EEG changes are under anesthesia. So right here, so just to orient you, this is just 4 leads of EEG. Up here you can see a little index, which is producing the EMG, and you're going to see that change quite a bit in just a second, all right? So like right here, we start injecting the Propofol. And you'll be able to know when it's going in. You see how you're seeing all these high-frequency oscillations on the EMG? See all this right here on the EEG? So that's muscle artifact. And the reason it's muscle artifact, because when Propofol is injected into a small vein, it actually burns. So Michael Jackson knew this. In fact, they had spent so much time trying to find veins to inject Propofol into him so he could sleep that the smaller the veins were, the more it burned. And he would tell people, you need to give me my numbing medicine before you give me my milk, meaning the Propofol, because Propofol is white. All right? And so typically we put a little bit of lidocaine, which we did here, into the IV in order before injecting it. So that's why you see this high frequency muscle artifact. But it's actually good because it'll contrast what's going to happen in just a second. So in about 4 or 5 seconds here, watch how the EEG changes. So right here, this is the first change. Now watch this. See this? I'm going to freeze it here. See these oscillations? Now these are very, very regular, like beta oscillations. Okay? That didn't take that long. Now watch what happens next. This is just a few seconds later, right here. Huge slow oscillations, okay? She's like, and look at the EMG. See how it's disappeared now? All right, so she's become unconscious right there. Didn't take that long. But watch this. Burst suppression, and almost, I'll play it for just a second or so longer. effectively flat, all right? Just with what we do standardly. So that's, this isn't, this is, we just didn't set this up. This is just what we do standardly. So I just want to talk you through like what's going on here, both sort of clinically and then in terms of neurophysiology. So that's what I understand. I understand what just happened there to this lady's brain or to this gentleman. All right, so let me just explain the first part, all right? So there was a reason I had him track my finger. So to remind you, here's the blood flow to the brain, so to this part of the brain. So the two vertebral arteries fuse and travel on the underside here. So this is the brain turned upside down. So here's the basilar artery sitting there, and the blood flows right along here. And so if we're looking at it from this projection here, we're looking right here. It comes right up there. And what's sitting here, down here, this is the ventral and dorsal respiratory groups, all right? So those are the circuits which control respiration. And if you look at how they're set up, there's a very rich array of inhibitory and excitatory neurons. The inhibitory neurons are GABAergic, all right? And Propofol works on GABAergic circuits. So it's very easy to see why one of the first clinical signs you would see once someone got a big dose of Propofol is you would stop breathing. This is why it's not to be used as a sleeping medication. It's way, way too powerful, as you just saw, all right? Now, if you move further up, so that's the first thing. That's why he stopped breathing. Now, all these colored dots that I have here are the arousal centers. So these are the centers that start in the brainstem, and they project up to the cortex, and they generate the arousal signals for the cortex. And these centers are quite redundant. So if you look here, this is the locus ceruleus, releases norepinephrine. These centers here, lateral dorsal tegmental area, pedunculopontine tegmental area, and the basal forebrain, they release acetylcholine. And the guys in the middle here, like the locus ceruleus, just like I said, and the locus ceruleus and the tubermammary nucleus, this releases histamine, and the dorsal raphe releases serotonin, and the ventral perioccipital gray, among a couple other areas, release dopamine, all right? So what's the relevance here? So right here, where the midbrain and pons join, remember the nerves come out, cranial nerves 3, 4, and 6, which control eye movements. So when neurologists are looking at the eyes, it's not so much they're interested in the eyes, they're trying to make an inference. And the inference is, if somehow your eyes are fixed and you can no longer move them, then it's likely that you've affected these arousal centers. And that's exactly what we saw, because as soon as he was no longer able to move his eyes, that's basically when he became unconscious. So we can actually see where propofol is having a very profound effect right off the bat. And the other thing which I'll just tell you is that onto each one of these arousal centers here, just like my fingers, so if the arousal centers are sitting here like this, there's an array of GABAergic neurons which come from the preoptic area of the hypothalamus, which sit there and are inhibitory. So you've got this perfect setup for propofol to hit these sites and basically inhibit the brainstem, all right? And the final piece is, why did this guy become atonic? Well, this is part of the reason. So I put my little friend over here from NASA, because, NASA's been interested in, motor control for a while, because, when the astronauts come back from the shuttle missions, we don't have, the shuttle missions anymore. The shuttle would land and you say, oh, that was another successful space mission for Discovery, another great adventure for the U.S. space program, right? And then the television would go off. You never see the astronauts hop out and have a news conference, right? Because they're spaghetti, right? They're carried off out of the shuttle, and then a couple days later you have a news conference with them. So understanding motor control is very, very important. And one of the key areas that's being studied, or had been studied in that regard, are these two relay centers here, the pontine reticular nuclei and the medullary reticular nuclei. They basically are relays. They go to the long muscles, the anti-gravity muscles of the arms and the legs. And if you take them out with a lesion, so when someone gets a stroke in the basilar artery because you get a clot there, when they present at the emergency room, as opposed to presenting spastic like this, they present with a flaccid paralysis. So it's not the only thing, so part of what we just did with the propofol was probably take out these relay centers. The reason I'm going through this is that I just want to show you that we can think through in a very kind of systematic way without doing any sort of studies whatsoever as to how the drugs have to be working, all right? So let's just push forward with a little more detail. So here's the EEG that I was just showing. Here's some still shots of it. So that's awake. And it's very important to get a sense of order of magnitude. So an awake EEG like this would be about 5 microvolts or so, right? These are the slow oscillations that I showed you right there in induction. So those can be anywhere from 20 to 50 microvolts, even as much as 100 microvolts in an adult. And then this is the part I'm going to talk about most, these alpha and slow oscillations. So we have oscillations which are quite slow, low frequency, less than 1 hertz, maybe up to delta, 1 to 4 hertz, and then oscillations like this, which are about 10 hertz. So that's kind of the primary anesthetic state of propofol, and that's what I'm going to spend a lot of time talking about. There's burst suppression, and so to just fast forward on one idea, when someone is placed in a medical coma on purpose, what you do is turn the propofol up until you get this state of burst suppression, and you hold it there, all right? So we'll talk about that in just a bit. There's the isoelectric EEG, the flat one, I showed you that earlier. And these other states up here, like the sedation, and this sedation state, remember when I said stop for a second? The first oscillations you saw there when the EEG, I said look at it, that's the sedation state. Those are the beta oscillations. And I didn't talk about paradox, I didn't show you paradox excitation, but we'll come to that later. All right. So I'm going to talk about this work, which has been done by a number of colleagues. So, the people who've really done the work are up here. So Patrick Purdon, Shenung Cheng, who's actually here, Nancy Capel's help with the modeling. She and Shenung have collaborated on that with us. Ahmad Eskandar is our colleague in neurosurgery. Sid Cash is a neurologist, and Eric Pierce has helped do the experiments, and Laura's also just finished up her PhD and has also been doing the experiments. So that's what I'm going to talk about now. So this is one of the protocols that we implemented. It's a very straightforward protocol conceptually. We just give propofol in increasing doses like this, and then we just measure the EEG, high-density EEG, and watch what happens. And then the person executes a behavioral task. Every 4 seconds, they have to answer a yes-no question. So we can get a very precise idea of when they stop responding or when they seemingly lose consciousness. So that's what this diagram here is just showing. So if you look right here, you see how this is, I'll just do it up here. You see right here, you see how this is just going up. Propofol is increasing. This is about, almost a little over 90 minutes or so. And then we let the propofol decrease. And there were 2 types of behavioral tasks which are sort of intermingled here. They're words and then just clicks. So the person has to respond to whether or not it's a word like table, chair, or his or her name, all right, trying to look at saliency. And then these over here are just basically clicks, auditory clicks, all right? And what you see is this particular individual, and this was true across all the subjects, they tended to lose their ability to respond to the clicks, the less salient stimuli, before they lost their response to the more salient stimuli. And then the more salient stimuli response came back first before the response to, let's say, the click. So that's just showing an individual. So this is kind of an average over the group of like 10 subjects that we studied in this protocol. And what I want to do for the moment is just have you focus on this right here. There is a 10 hertz oscillation when you're profoundly unconscious, and there's a slow oscillation, right? And what I want to do is spend a little time dissecting how that comes about and what we think its significance is, all right? So to do that, I'm going to start here. So this is the EEG of one of the subjects. And there's 64 leads, but this is going to show you 44 leads of it. And this is the EEG had taken at different parts across the head. So this is the nose up here, this is the left ear, this is the right ear. And if you look back here in the back, so this is the back of the head, this is the occipital area. And as you know, if you close your eyes like this, right, and you put EEG on the back of the head, you'll get a 10 hertz oscillation with your eyes closed, all right? It's well known. Pretty much everybody has it, maybe 5 to 10% of people don't have it. We tend to lose it when we get a little bit older, but it's pretty robust, all right? So that's known. The other thing that's been known for years is that as you lose consciousness under anesthesia, there's a wave that goes from the back of the head to the front of the head, and it concentrates in the front of the head. And as long as you keep the person unconscious, that oscillation stays there in the front of the head. And then when they recover consciousness, the wave moves back, all right? It's called anterior ization. This was figured out by John Tinker and John Mitchenfelder back in the 1970s. They were looking at this in monkeys, all right? So I'm just going to show you that because it gives us a lot of insight to the dynamics of what's happening under anesthesia. The key point is that anesthesia is not a state in which the brain is turned off. It's actually highly dynamic. And I'm just going to show you this. I'm going to play this forward. So you can see, look, this is a 2-hour experiment. So here's the baseline. You'll see when the drug levels change. All right, so that's the baseline. Now the drug infusion starts. So you see right here, it's starting to infuse. Now you're going to see this 10 hertz oscillation disappear back here. And now it's moving forward. Now it appears in the front. It actually appears very strongly. It's not subtle. All right? So I'm just going to stop it right here. All right? So look. See, this has been replaced by a slow oscillation back here. This is pretty much faded out. The 10 hertz has. Now look, the 10 hertz is up front here, and there's the slow oscillation. But I want to point out a specific pattern. So this is like the top of the head. This is about right here. And if you look from here going forward to here, there's a different dynamic than from here going backwards, all right? There's a different dynamic in the front part of the head compared to the back. So we'll just play it the rest of the way. So now this is the deepest level. You can see the 10 hertz oscillation is well concentrated up front with the slow oscillation. And now as you drop the level of the drug back, this disappears in the front and it goes backwards. So it went like this and then like that. All right? So what happened here? So this is where the modeling work that we were able to do with Shenung and Nancy helped us out tremendously. So as I said, Propofol enhances inhibition, okay? So it actually makes GABAergic interneurons sort of more effective. And here's that circuit I was telling you about. See, this is the preoptic area here. And see, here are these inhibitory inputs which come to all of these places right here. So the drug actually is acting here as well as in the cortex and also in the thalamus. So pretty much anywhere you have these inhibitory networks, all right? So that's just from sort of the molecular pharmacology, if you would. But this is actually from the operating room. So this is one of my patients in the operating room. So this is a 10 hertz oscillation. There's the slow oscillations. You don't have to do studies to see this. It's really, really obvious. All right, so here's what we think is going on with the 10 hertz oscillation. There's that concentration of it in the front. And these are things we were able to sort out, as I said, with the help of Shenung Cheng and Nancy Coppell. So what we deduced first by modeling is that what's likely occurring is that this 10 hertz oscillation is an oscillation between the thalamus and the cortex, all right? It's very easy to drive the cortex. It's very easy to show with modeling. You can drive the cortex down to 10 hertz. Moreover, with the properties of the thalamic circuits, it's easy to generate a 10 hertz oscillation in the thalamus. So the two couple, all right? And there's a reason that they couple anteriorly as opposed to posteriorly, because there's a different anatomy going posteriorly compared to anteriorly. We'll talk a little bit about that in a bit. But this is actually what you were seeing. This is that 10 hertz oscillation coupled across the front. All right, so what's the significance of this? Well, see, you never hear about anesthesia until it screws up, right? You know, after 170 years almost, anesthesiologists can't figure out whether someone's unconscious, right? And nothing could be further from the truth. See, this is not standard in most operating rooms. People do not monitor the EEG in patients under anesthesia. If they did, they could know this. So if someone came to me and said, Emery, the last time I had anesthesia, I had awareness, blah, blah, blah. I said, that's not going to happen. Because if you dial them down to this state here with Propofol or one of the other drugs, then it's going to be very difficult for them to be conscious, because here's what's occurring. So remember, the EEG is like this when you're awake, right? And then it's doing this. It's doing this with very, very regular, highly structured oscillations. And if we're correct, and we sort of verified this experimentally, you have this very strong oscillation going back between the thalamus and the cortex. If you could pick decide of one area to really tie up to impede information flow, it's going to be the thalamus. The thalamus is a center. It's like a good midfielder on a soccer team, right? Information goes forward as well as backwards. And so if it's tied up in an oscillation like this, it's going to be very hard to transmit information. It's literally like me taking what I'm saying to you now, and you say, okay, Emery, I want you to continue to give the lecture, but I'm going to give you one frequency, and you have to keep the amplitude the same. So what I'm saying now will become wah. And as long as you keep the drugs flowing, that's basically what happens, right? So now if you think about it, there's no natural state where we do that. That just can't be good. I mean, it may not cause problems after the first anesthetic, maybe not after the second, but it's not something you want to do every day. It's certainly not something you want to do to try to sleep, all right? So there's no way in the world that could be sleep. All right? So that's the alpha oscillation. Now, with the slow oscillation, the life is a little bit different. What's interesting is they tend to come on roughly at the same time, where you actually saw when the slow oscillation came on. But with the help of Ahmad Eskandar and Sid Cash, we've actually been able to tease this apart in a lot of detail. So like at our hospital, like in many others, they do epilepsy surgery where they implant grids and depth electrodes to record to actually locate the epileptic foci. So the patients have a first surgery, they do the implantation, they stay in the hospital for 5 to 7 days, they seize enough, they figure out where the seizure focus is, and then they come back and they do an explantation and they do a resection. When they come back the second time, you've got this incredible situation. I mean, you have humans that have electrodes in the brain, so you can actually see what human neurons are doing. So this was Laura's PhD thesis. And from this, we're able to figure out a lot about the slow oscillation. So whereas the 10 Hertz oscillation is quite coordinated, quite synchronous across the front of the front of the scalp, the slow oscillation isn't. The slow oscillation is quite dissynchronous. And so that's what this is actually showing here. So this red dot right there is this red slow oscillation there. And this green dot is where this green slow oscillation is. So these are two sites. So they're like this. They're close together. They're close together. So they're in sync. They're doing this. All right? You move just a centimeter or so away, and the oscillations are like this. All right? So that in of itself isn't all that interesting. But you see these little histograms right here? Laura made these histograms to show where the neurons are spiking, all right? So the neurons are only spiking at the minimum of the slow oscillation, okay? So if you want to communicate with this guy over here, it's going to take you a while before you can get something going from here to here, which is only a few centimeters away. So this is also making it more difficult to transmit information and contributes to you being unconscious. So you have two profound things going on. The slow oscillation here, and the alpha oscillation. So this is just to say, with the help of modeling, we've actually gone through and looked in detail at the anteriorization. And this is work that Shenung has done along with Sujith Vijayan, and Nancy's group, to sort of distinguish a little bit of the differences. But, again, I can't emphasize the modeling enough, because this is a series of papers that we've published looking in detail at both the paradoxical excitation and then Shenung's paper back in 2010, looking in detail here at these alpha oscillations. And that's where, he and Nancy put together this idea of this, thalamocortical oscillation. Because the system doesn't shut down because it's a highly nonlinear system that's interconnected. And if anything, what you're doing is basically finding the mode. And then you can actually extrapolate from this, and we've actually seen it. When you change the drug, it has different receptor binding properties, you get different oscillations because it's affecting different circuits. And so then how the drugs are working starts to become much more apparent. So this is what I just said. So the 10 Hertz oscillation is like a pathological hum. The slow oscillation is sort of marking this kind of fragmentation. I showed you this anteriorization. You have a different dynamic in the front of the head from the back of the head, which is one of the reasons why this idea of frontal parietal disconnect is certainly plausible. But don't forget, the first thing I just showed you clinically is that the drugs have this very profound effect in the brainstem there. So that it's all these things together that are contributing to someone being unconscious under anesthesia. All right? So I want to tell you a little bit about this closed loop control. And this is work which Shenung has been involved in, as well as Miriam Sinichi. Miriam's right over there too. And Ken Salt did the experiments, as well as Jessica did also the experiments and the modeling. All right, so burst suppression. So burst suppression is this very profound state of anesthesia. And I showed it to you on the little video. And it's very easy to go into. Pretty much all older people, as soon as you induce anesthesia, they go rapidly into burst suppression. It's almost difficult to prevent it when you're using propofol and induction with sort of the standard doses that we use. But what's interesting about it is it's a brain state which is generated by a number of other conditions. So hypothermia, it shows up in coma, and this very unfortunate syndrome, developmental syndrome, in kids called Ohtahara syndrome, where the brain is really hypodeveloped, and as a consequence, it's just kind of in this agonal state of burst suppression. Unfortunately, this isn't compatible with life for too long a period. And then also in newborns that have had a post-asphyxic event, often show up with these refractory seizures. All right? But what I want to talk about is using so we started studying burst suppression because you have 4 or 5 different things which produce a final common pathway. Anesthesia is the parametric way to generate it, so it suggests a way to come up and understand what may be occurring with burst suppression. But what I want to talk about is using it therapeutically. So when someone has a head injury or they have intractable seizures, they're placed in what's called a medical coma. So, you know, remember Congresswoman Gabrielle Giffords a few years ago? Just recently, over the Christmas holidays, Michael Schumacher had a skiing accident, was placed in a medical coma for several days. And Malala, the young woman from Pakistan who had a head injury, they placed her in a medical coma. And as I said earlier, all a medical coma is taking the propofol, dialing it down until you see the burst suppression on the EEG, and you hold them there. You hold them there for 5 to 7 days. So now the way this is done presently is someone, usually a nurse, is sitting there periodically changing the concentration on the infusion pump, the settings, in order to try to keep the state of burst suppression. Now, if you're going to do this for 5 to 7 days, or sometimes even longer, that's just like saying I'm going to fly a plane for 5 to 7 days, but I'm going to keep my hands on the yoke the whole time, right? If ever there were a chance to build a controller, you know, this was the opportunity. So that's one of the things that we looked at. So we got some rat volunteers, and we put EEG on them. And so here's their EEG, okay? And it's very easy to convert this EEG, which is in burst suppression, into 1s and 0s. So whenever you have a suppression, that's a 1, and whenever you have a burst, that's going to be a 0. So this is that EEG converted into 1s and 0s. And then using some of the filtering ideas that we've studied for a while, these sort of Bayesian filters that actually operate on binary signals, under a model, a very straightforward, simple pharmacokinetics model, you can estimate kind of the level of propofol in the brain. You have a target level that you set. I'll tell you how we set that in a second. But then you can control this and use it to control an infusion pump. And the way we set the target level is through what's called the burst suppression probability. In other words, you can look at the fraction of time that you want the person to be in suppressed. So if you say 50% of the time, then 50% of the time you'd be suppressed, 50% of the time you'd be bursting. If you wanted to be 75%, then 75% of the time you'd be suppressed, and 25% of the time you'd be bursting. So with that, you can actually set indirectly a target propofol level for the brain. So we did this, and we used several different control strategies, PI control as well as LQR and MPC control to look at this. So Miriam made a video of this, all right, which I'm just going to show you here, showing how this works. It's easier to illustrate in the video than it is just sort of talking about it. So I'm just going to stop it here. All right, so this is the EEG up here. Okay, so what Miriam did first was set a target level of 0.4. So that's the target level. That's what the controller is supposed to achieve. And here's the controller here, what it's going to do. And then this down here is basically the infusion pump, how the infusion pump is actually changing the rate of propofol infusion to achieve it. And so the time scale here is minutes, all right? So we're going to have target levels going for about 15 minutes and then changing them. So I'll just play this forward. So this is the controller trying to reach and maintain 0.4. So 40% of the time, expecting the animal to be suppressed. And now we change the level, so taking up to about 0.7 or so here. And you can see, look, there's a different dynamic here for the infusion rate here compared to there. And the EEG, which was up here, is now down here because it's more suppressed. And now if we change the level again to take it almost to 0.9, so the controller moves up to 0.9, the target moves up to 0.9, the controller follows, and there's a whole different dynamic here with the infusion. So you can imagine this is very difficult if you want to have this sort of level. This is updating basically every second. Now practically you wouldn't have to do this in the ICU, but it just shows you that it's possible. And so here, I showed you this one here, sort of going up, but we did it a number of ways, going up, coming down, and the reason this just drops down like this is to decrease the level of burst suppression, if you would, or the burst suppression probability, we have, you're depending upon the kinetics of the body. I'm not giving you a drug which actually causes it to come down. We're actually letting the body take care of it. And so, but this fall off is basically what you'd predict based on the kinetics. But you can see the control is actually very, very good. So this is one thing, like with the help of Brandon Westover, is one of our colleagues in neurology at MGH. We're looking to try this out in humans in the ICU there. All right. So this is just the statement. Something like this is probably possible, and you can imagine extending these ideas to controlling anesthesia in general. So I just want to leave you with one thought, sort of looking forward to the future. The first thing I talked about was how a current drug works. The next thing I talked about was how you might control the brain under anesthesia using current technologies. So Ken is kind of out there. I mean, he's asking some questions like, well, look, if we're giving you anesthetics to keep you anesthetized, maybe what we should do when we finish is like turn the brain back on. So he's looking at ways to turn the brain back on. So I just want to tell you a little bit about his work because I think it's pretty interesting. So I'll just show you. So he also works with rodent volunteers, and so this is a rat who's in a chamber of isoflurane, and he's been there for about 20 minutes. Okay, and he's anesthetized, and he's got this IV in his tail vein here, and there's an infusion here which is set up. And so Ken is just going to inject some normal saline here. Just basically to show you that injecting normal saline doesn't really do anything. So the rat is still unconscious, so a little bit of time goes by. The anesthetic's held the same, nothing's changed. And so now he's going to inject here one of the test drugs. This is going to be intravenous Ritalin, all right? Inject intravenous Ritalin here. All right, so now if you flush it into the system, remember the anesthetic's not turned off, right? He's still receiving anesthesia. Let's just say there's a state change of some sort. Okay. We'll be conservative with it for the moment. Right. All right. Now, the anesthetic's still there. So he's got to flip over for it to count. It doesn't count if he doesn't flip over. He's caught in the cables there. He does make it. I've seen the end of the video. There he goes. Okay, so he made it. Good. All right. So then he tells a friend about what Ken is up to. And so Ken this time has an infusion of propofol going into this rat here, and he has an electrode targeting his ventral tegmental area. This is an area in the brain that releases dopamine. And it's the sort of the origin of the mesocortical pathway. Just going to show you this. So you can see you can see the animal breathing there. So the IV in the tail vein here. The electrode in the ventral tegmental area. So it's off now. So now he's going to turn it on. So this is electrical stimulation. So he turns it on. See how he started breathing really fast first? Remember, he's still getting an infusion of propofol. And he's out of there, okay? So what is happening here? So this is the first scenario. So you know that when you give Ritalin actually increases it blocks the reuptake of dopamine, at the synapses, pretty much everywhere. So you get this large increase in dopamine everywhere. And so it happens in all the pathways, but the relevant one here is this one starting at the ventral tegmental area. So this is the mesocortical pathway. Here's the mesolimbic pathway. So you're getting an increase in dopamine in all these areas. And it probably also increases, probably histamine and maybe even norepinephrine. But let's just say it's dopamine. We have good reason to believe it is primarily dopamine. All right? So that's one situation. That was the first scenario. Then the second case, what Ken did is he comes here and electrically stimulates the VTA directly to sort of activate this pathway. Now, one of the reasons this is important is that we normally think about this pathway in terms of reward, but it actually turns out to be a fairly important arousal pathway as well. It's one of those, 6 or 7 that I was talking about, which is at the base of the brain. So then how is this working overall? So this is kind of like that paradigm I showed you. So this is someone who's basically awake. So if you're like this pyramidal neuron here, sitting in the cortex, you have the inner neuron telling you what to do. You have these excitatory inputs coming from other areas, but let's say one large area is coming from the arousal centers. So it's a balance between inhibition and excitation. All right, now, when you anesthetize with propofol, or it turns out with isoflurane the same way, you basically shift this more towards this inhibition. All right, so the thing is shut down. All right, so that's the anesthetized state. Now, if you take that anesthetized state and you administer Ritalin, it's not that you're not blocking the propofol, but you're just enhancing this excitation, all right? Now, clearly, if you wanted to wake people up, you wouldn't leave the propofol on. You would turn it off, so that would help as well. But the point is that you're just shifting the balance more towards excitation. So one of the ideas is that this might be a way to bring people out of anesthesia, and if it's working through this ventral tegmental pathway, this mesocortical pathway, that could be a good thing, because in elderly patients, depending upon which study you look at, 30 to 40% have some sort of cognitive dysfunction following anesthesia. And this is one of the key pathways that needs to sort of come back online to sort of help that. So Ken has permission now from the FDA to start testing this in humans. He's going to start that later next month. So this is the idea. Maybe administering some sort of dopaminergic agonist could induce reanimation from anesthesia. So this is what I've told you, that the propofol creates these altered states of arousal by changing brain dynamics. And I could slip in another anesthetic there, because we see this in all the drugs now. What they do is they basically drive the brain in these oscillatory manner, and it makes it hard to transmit information. It's not that it's just necessarily shutting the brain down unless you give like mega doses, right? But it's causing oscillations. And none of these oscillations is natural. And so right there you can start to understand why you would begin to have problems. So this is giving us insight into some of these more precise, thinking more precisely about the mechanisms. It also suggests a way that we can monitor the brain. I showed you that. But then as soon as you realize that this is what these drugs are doing, it really compels you to think of alternative approaches to doing this, because 60,000 people a day get anesthesia in the United States alone, and that just can't be good for health long term. So I'll stop there. Thanks a lot.
Hi. How does the first part of your talk relate to the so-called depth of anesthesia monitors? And what do you think is the usefulness or effectiveness of these type of monitors?
That's a good question. So, I think that those monitors, the way they're set up, where they ask you to just look at an index, I think they've done us a disservice, okay? Because it was known for a long time that EEG changes, like I just showed you, occur as people transition through different stages of anesthesia. And what it's done is it's gotten us away from thinking about what might be causing those oscillations or causing those dynamics, and using those, following the EEG, either with the spectrogram or the raw EEG to actually know the state. You can actually know it far better than if you're just looking at a number. These indices, these depth of anesthesia monitors, process the EEG and give you back a number. And they run into problems like all the time. They're really obvious caveats where they just can't work. So I think the way to do this is to learn to read the EEG. And we actually have a whole teaching program like for our residents and faculty where that's what we're teaching them to do. Because the different drugs, it turns out, have different signatures. You can see them. And they're a very systematic way that these signatures change based on how you dose the drug and how old someone is. So you can actually read the state of the brain, fairly accurately. And I think that's the sort of thing we should be doing as opposed to using depth of anesthesia monitors, which just reduced the whole thing, a very higher dimensional, not intractably high dimensional, but a higher dimensional problem down to one dimension, which after a while gets to be quite inaccurate.
Could you also comment on the dynamics of the brain during sedation in the ICU, and what parts of the brain do you think are more active, and do we really need a full set of EEG electrodes to monitor patients for sedation?
I think that's a very, very good question. You know, it's amazing. You know, intensive care, except in the neurointensive care, means intensive care for every organ with the exception of the brain. You know, it's not typical to monitor the brain when patients are sedated in the ICU, and in most cases, people don't realize how sedated patients are. In fact, they're profoundly sedated. And part of that sedation actually comes from just their natural processes. So inflammation turns out to have a very, very strong soporific effect on the body, on the brain. In fact, you know, just think about it. When you get sick, when you have a cold or a flu, you don't feel like running a marathon, you feel like going to bed. And so you can imagine if someone has like a rip-roaring infection, or if they just had surgery, activated the inflammatory system, the immune system, that actually is a sedative right there, right? Then on top of that, you're dosing the drug not based on a measure of how sedated the brain is, but just based on your intuition about how big this person is, or basically, you know, how much they weigh. And they're quite off. I can tell you that from what we've seen, Patrick Purdon and Brendan Westover at our hospital looking at this now, the patients, I think, across the board are over-sedated, and they're in very, very profound states of sedation, like the ones I showed here. And in particular, the anesthetic requirement that you need to actually maintain that sedation is actually decreasing the longer that the people are being sedated. So my recommendation is that we start monitoring people's brains in the ICU, because they probably do not need nearly as much drug as being given. And I can see it when they come down to the operating room, that they have a sedation pattern which is quite distinct from the ones that we normally see in the OR. So I think that's an area where a lot of progress can be made very, very quickly using some very simple technologies.
Thank you very much for your presentation. My question is about do you know that the dynamic change produced by Propofol are similar to the change produced by other anesthetics like ketamine?
Yeah, so the dynamics produced by Propofol are quite different from the ones from ketamine. So first of all, so again, the way we think about it now is, so you take the receptors where they act, and you take the circuits, okay? And so ketamine acts by blocking NMDA receptors, all right? So at low dose, it actually is more effective against NMDA receptors on inhibitory interneurons. So instead of the brain slowing down, it actually speeds up. So you actually have like a 30 hertz oscillation, very regular 30 hertz oscillation, which looks quite different from Propofol. As you increase the dose of ketamine, like you might do if you're giving an induction with ketamine, then as you get to the NMDA receptors on excitatory neurons, now you start to see the larger sort of slow oscillations. So the dynamic depends critically on the receptors and the circuitry where it's acting, but it's markedly different from Propofol. It's not subtle at all. Question?
Could you please comment on any neuronal loss during the full anesthesia, and whether there is any way to recover all the neurons, especially if the total anesthesia happens to Alzheimer's patients or elderly patients?
No, that's a good question. Is there neuronal loss? So this is a question which is actually being actively studied for young kids in animal models, sort of young kids, in which what they've shown is that in animal models, the anesthetics are toxic. Pretty much all the standard anesthetics we use are toxic in the sense that they're given doses which are a little bit larger than what we normally give, to be fair, but they induce apoptosis. All right, that's the statement. And so my colleagues in pediatric anesthesia are now trying to figure out, this seems to be robustly identified in animal models, is it true for children? And the answer there is they don't know. So the smart tots effort, which is a partnership between the IRS, the International Anesthesia Research Society, and the FDA, is trying to sort that out. Okay. In older patients, I don't know that we have any notion of apoptosis, but what's very, very clear to me, so most anesthesiologists know that you don't have to give as much drug to older people to have them be anesthetized at the same state equivalently. But it's very clear that if something like this is a pathologic oscillation, I'm calling it a pathologic oscillation because it's not natural, that as the brain gets older, it's just harder to tolerate that. I mean, just back of the envelope thinking, right? So that really says that what we have to do is we have to think about alternatives to this. We have to come up with different approaches, more site-specific approaches, because it can't be the case with the population aging that that's going to be the sort of thing that's going to be tolerated, long-term, because more people are older and in important positions wanting to come out of surgery and go back to work, as soon as possible. Now, there are data that suggests that the inhaled drugs do enhance some of the processes associated with Alzheimer's. I mean, that's been kind of robustly shown by Zhang Zi, who's at Mass General. So if you think about what we're talking about is, we're talking about ether, was first used in 1842, 1846. Isoflurane that we're using there, sevoflurane, desflurane, they're all ethers. So we haven't made much progress in that regard. So the real thing is to stand back and say, okay, guys, all right, it's very likely these things are harmful. We didn't build any of them from first principles. Why don't we build first principle anesthesia? I mean, that's what we have to do. And with the neuroscience that's, sort of being produced now, I don't think that's an intractable problem.
It's actually a follow-up question. It looks like all the technology right now is based on drugs and chemicals, and at some point can apply electric fields or currents, and the red volunteer went into a different anesthetic state. So what do you think about this new field of electroceuticals, or applying electric fields, electromagnetic waves, or ultrasound to be able to achieve anesthesia and maintain it without maybe side effects, or maybe with more side effects?
So put it this way: I think it should be investigated, probably in some of the rat volunteers first, just to sort of see what's going on. But I think that the need to be more. But again, what's going to help us is if we know precisely how it's working, okay? And that's kind of one of the question marks with these approaches in general. Exactly what area they're targeting. Does it actually excite an area? Does it inhibit an area? How narrow is the focus? Are you actually identifying, specific cell types or nuclei? So all those questions would have to be answered, in this context. And can you do it real time? I think those are exactly the sorts of things we should be investigating, because I only know of 2 new anesthetics that are in development right now. I'm sure there are more, but I only know of 2. And if it turns out that the only thing that we're hearing is the drugs are toxic, right? We're going to be squeezed more and more without any new ideas on the horizon. So I think this is an area which is very, very ripe for research with these techniques and others.
Do you see any future in that direction in terms of it would be possible or not possible using electric fields to achieve anesthesia?
So I can't speak to its plausibility because I haven't tried it, but what I'm saying is I think it's worth trying. I think it's worth trying to sort out.
So at least you don't see any red flags immediately.
Right, but don't go home and try it in your garage or something like that. That's all I'm saying, right? Get some rat volunteers and then, first, okay.
You gave us some excellent insights on how anesthesia affects the ascending arousal system.
Mm-hmm.
Now, we know that the same circuitry is modulated by the circadian generators.
Mm-hmm.
Can you comment on whether there's a role for taking circadian modulation into account when you perform these procedures? Is it easier, harder to induce and maintain anesthesia, certain phases, that kind of thing?
I can honestly say that, giving anesthesia in the middle of the night or giving it during the day, I've never seen like a circadian effect, in the sense that, what you might postulate is, so the circadian nadir is somewhere around 4 a.m. in the morning, like in humans. And so you might postulate, well, you just give them, 2 drops of propofol and they should be out. Whereas, way in the middle of the day, coming up around 3 o'clock in the afternoon, 5 or something like that, when it's at its maximum, it might be harder. I can't say that I've seen that. Because, these effects are so profound. That's why I'm going to show you the videos, right? So again, just to put this in the context, your EEG is about 5 microvolts if we're sitting here now. It goes to 20 to maybe 50 microvolts when you're profoundly anesthetized. In kids, this goes to like 3,000 or 2,000 microvolts in some cases, right? So it's a huge change, and it's not affected by that sort of more 24-hour like time scale. However, the things that do affect it are, if you've just had a sedative, or you just had some alcohol, that sort of thing, it will take less to induce you, right? A kid who comes in, for example, and has taken his Ritalin that morning, and forgot that he wasn't supposed to take it in the morning, it will take more anesthesia to induce and maintain the anesthesia than if he hadn't taken, the Ritalin, sort of thing. And that's very important for pediatric anesthesiologists because they find themselves dialing up the anesthetic, and they're getting well beyond doses they might normally give a kid. So in that case, those sorts of things for sure. So state changes, which are like that, will certainly affect the amount of anesthetic necessary. But long time scale changes, like on the order of 24 hours, the circadian diurnal variation, I haven't seen that.
I have heard about Chinese anesthesia by needles only put in some region. Is it truth or myth?
No, it's very true. In fact, I've seen some nice videos where they actually are able to do thoracotomies, really open the chest with acupuncture.
It's not worthwhile to study.
Beg pardon?
It's not worthwhile to study to get scientific background.
I think it is. Believe me, I think it's very worthwhile. I think it's worthwhile for a number of reasons. And so this is just, and it might be a juncture just to point out a little bit of the politics. So like right now, see anesthesiology is viewed as like a clinical kind of service. It's not viewed as something which is like scientific and kind of worth looking at and sort of sorting out. But yet, there's the whole microcosm of clinical neuroscience that happens in anesthesia, in the sense that you can find models for schizophrenia, you can find ways to maybe treat depression, you get ideas about what sleep should really be like, you have drugs which can create like locked-in syndromes and this sort of thing. But like right now, research at NIH is supported by NIGMS. So NIGMS is starting to focus more on basic science at the moment, right? Basic science, which doesn't include neuroscience, which is what anesthesia is. And anesthesiology has never had a home in fields like, sort of like NINDS or NIMH or, NIDA or this sort of thing. So there's this disconnect as to sort of where those investigations, should be done. And that's the reality, yet there are all these exciting questions which come up about brain state control, which could be well addressed or looked at through anesthesia.
Thanks a lot for your answer.